Hey everyone, welcome to week 6 of our PSPirates session. Today we'll be starting off with Claire, who will be taking you guys through lower limb.
Okay, so yeah, I'll be taking everyone through lower limb number 3. So for this section, you actually don't have any learning objectives and there's actually no lecture on it. So I think you just learn it through tutorials and anatomy sessions in person. So I hope these notes cover everything. Otherwise just send me a message. So to start with, you have 3 sections in your foot. You have the tarsals, the metatarsals and the phalanges. So very much like the hand. With the tarsals, you can see the bones over on the left-hand side. So you have the calcaneus, and this is actually what you're standing on in your heel. And then you have your talus, and that's what is joined with the tibia and fibula. And then you have your navicular here in blue, your cuboid and your cuneiforms. And so these you have 3, the medial, intermediate and lateral. So yeah. So moving on, your talocrural joint is formed between the tibia, fibula and talus. And that's what essentially is supporting your foot, moving up and down. So when you're walking, essentially, and it is supported on the medial side with 4 ligaments, and collectively they're called the deltoid ligament. And then laterally it's supported by 3 ligaments, as you can see, the anterior talofibula, posterior, and the calcaneofibula. And pretty much with these ligaments, it's just, if you read the name, it says where it's going. So talofibula, it's going from the talus to the fibula. So they're pretty self-explanatory. And then the subtalar joint is between the talus and the calcaneus. And that's essentially for inversion and eversion of the foot. So yeah, I do remember them asking us possibly a question on this deltoid ligament. So yeah, probably know that. Moving on, so the dorsum of the foot is actually the side of the foot that you don't walk on. So there's only 2 muscles, which makes it pretty easy to remember. And if you're just applying it from everything that you've learned from the upper limb, you know that the extensor digitorum brevis is only is extending all of your toes, except the extensor hallucis brevis just extends your big toe. Except the only extension here is there's no attachments on the dorsum of the foot for the little toe. And then so moving on, the plantar foot muscles are what you actually tread on. And we divide these up into 4 layers. And so innervation is via the tibial nerve. And this runs through that talofibular joint on the lateral malleolus that we went through last week. And it's a branch of the sciatic nerve that comes out from the back of the lumbosacral plexus. And the vasculature is via the posterior tibial artery. And again, it divides into medial and lateral plantar arteries. So these layers I will go through now in the next slide. So this first layer is the most superficial, essentially. And again, if you just read the name, if you understand what they're saying, then you can understand the function. So abductor digiti minimi means it's abducting, so it's spreading the little toe out. And then adductor hallucis means it's extending the big toe out. And then the flexor digitorum brevis is essentially what's pulling your toes downwards, as if they're going into the floor. So your second layer is made up of your quadratus plantae and your lumbricals. And then following that, you have your third layer here. And again, if we read the names, you can see that the flexor digiti minimi brevis means that it's moving your little toe down, whereas the adductor hallucis is moving your big toe inwards, so it's bringing it back in, and your flexor hallucis brevis is bringing your big toe downwards as if it's going into the floor. So yeah, flexion is going down and extension is back up. And then this is your deepest layer. There's the dorsal interossei, and I think they're the plantar. Sorry, I don't know why that image is cut off, but they essentially help in abducting and adducting your toes, except as you can probably tell, you don't have that much movement in your toes to do that. So they're not too important. Moving on to the veins of your foot. So the dorsal side of your foot, which is this top area, you can see here, it mainly drains to the saphenous vein and the posterior tibial vein. And these are the dermatomes of the foot, so the cutaneous innervation. And for the nervous supply of the motor, the dorsal compartment is supplied by the deep fibular nerve and the plantar compartment is supplied by the tibial nerve. And in comparison, for sensory innervation, it's primarily provided by branches of the tibial nerve and superficial peroneal nerve. This is just the last slide. These are the dermatomes of the lower limb. I do remember, and these are the myotomes, so what actual nerve branches are controlling movement. And I do remember like some questions on the myotomes or the dermatomes. So I would recommend knowing these because like when you're testing for something, if it's not working, then you can specifically pinpoint what nerve and then possibly which nerve roots are being affected. So you'll probably get to that too in the lower limb examination of the foot, which we'll be going through next week. But if anyone has any questions, just let me know and I'll stop screen sharing now because I think that's the end.
Okay, brilliant. So I'll be taking many of the pharmacology lectures this semester. And for week 6, there are 2 lectures on anti-inflammatory drugs. The first one kind of being just a general introduction into what inflammation is, the kind of mediators that are involved. And then in the second lecture, you'll look more into specific classes of anti-inflammatory drugs. So we'll look at each of those classes today and discuss some of the examples for them as well. So just these learning objectives quickly to make it super clear. So we're describing main symptoms of the inflammatory response, the main mediators responsible for inflammation, medication used to relieve these symptoms, the mechanism of action of simple analgesics and NSAIDs, and then any side effects that are associated with those classes of drugs. So beginning with acute inflammation of just the key symptoms of acute inflammation. So we have 5 cardinal signs. We've got pain, heat, redness, swelling, and loss of function. And you might sometimes see these referred to via their Latin derivatives as well. And then just kind of explaining why these inflammatory symptoms occur in a bit more detail. So with pain, you often get release of prostaglandins. So these will open your voltage-gated sodium channels. You've got more firing of afferent fibers, which enhances the feeling of pain. And this can also result, the pain response can also be a result of kind of physical distortion of the tissue as well. Heat and redness are pretty similar in terms of the kind of pathophysiology. And you've got essentially a vascular change here. So you've got vasodilation of your arteries, which leads to redness. You've got increased blood flow because of an increased permeability of microcirculation. And what this does is it increases the viscosity of your blood. So essentially slows the blood flow. You've got fluid moving into the extracellular space. And then you've got more interendothelial gaps. So these all contribute to kind of heat and redness, but the key takeaway here is that it's a vascular change. So it's to do with your arteries. With swelling, this is to do with your lymphatics. So you're going to get a buildup of what we call cellular exudate, and this will ooze out of your red blood cells and deposit into nearby tissue, which leads to kind of the accumulation of smaller cells known as neutrophils. You've got an increase in lymph flow, which will then drain fluid, neutrophils, and other kind of cell debris from the extracellular space. Sorry. And then lastly, loss of function is not too deep in the same kind of pathophysiology sense. It's just more that the pain response is going to inhibit movement or mobility as well as swelling. So just looking at some of the mediators, this isn't too high yield. You don't really need to know their role in too much detail. It's just kind of being aware of all the different kind of inflammatory mediators that could be involved in an inflammatory response. So some of the key ones we have are histamine, 5-HT, eicosanoids, bradykinin, neuropeptides. So histamine will be involved in your vasodilation, your increased vascular permeability. So if you remember back to the previous slide, this will therefore have a response in kind of redness. We've got 5-HT, which will activate dendritic cells. So you've got your immune response happening here. So you've got T cell proliferation, got lots of immune cell recruitment, and then pro-inflammatory cytokine production. Your eicosanoids include your prostaglandins, your thromboxanes, your leukotrienes, and your LXs, and these all have a range of different functions in terms of inflammation. Bradykinin is particularly with vasodilation and increased vascular permeability, and then neuropeptides have a number of epithelial functions in particular. Just a few more, we've got cytokines, which all have a role in immune response. So particularly leukocytes, neutrophils, macrophages are important here. Complement will increase vessel permeability and lead to histamine release. And then lastly, you've got platelet activating factor and oxygen-derived free radicals, which also play important roles. Okay, so that kind of addresses the main introduction into the inflammatory response and kind of the key mediators involved. Today, we're going to look at simple analgesics and NSAIDs. There are kind of 4 classes of medications that you will cover, but we'll be going through opioids and anesthetics, I believe, in kind of week 8. For this week, it's just the first 2 here. So there are some drugs you need to know in particular, and these all come from the lecture, and you can find them on ePharmacology or the Australian Medicines Handbook. Both of these resources provide really, really useful information about these drugs. So I've essentially compiled these drugs into a table for you guys, just kind of comparing the mechanism of action, when you might use them. So that's what indications are, and then kind of common side effects from each of these. So with aspirin, you get an irreversible inhibition of platelet cyclooxygenase, so COX-1 and 2, which I'll go into a bit more detail a bit later, which essentially prevents the synthesis of prostaglandins. And if you remember back to the inflammatory mediators, these play a role in inflammation. Paracetamol, the mechanism of action is actually unclear, but it's suspected that there might be, similarly to aspirin, some kind of prostaglandin inhibition more at a central level. So you're thinking of your hypothalamus. For both of these, you use typically when there's fever or mild to moderate pain, but with aspirin, quite common in the treatment of rheumatoid arthritis, as well as rheumatic fever. In terms of side effects, gastrointestinal side effects are pretty common to aspirin. You've also got other things like nausea, headache, dizziness. With paracetamol, it's really careful that you don't exceed 4 grams daily, because this can have a pretty detrimental effect on the liver, and then also other gastrointestinal issues there as well. Oh, and if I was just to compare the two, between paracetamol and aspirin, generally paracetamol has better gastrointestinal tolerability than aspirin. And also you can use it in children in a syrup form, which might make it easier, kind of for children to take and for their symptoms to be relieved. Now looking at a few NSAIDs in particular, so you've got ibuprofen, meloxicam, and diclofenac. Meloxicam here is the only one that is selective for COX-2. So both ibuprofen and diclofenac are non-selective, which means they kind of affect both COX-1 and COX-2. So COX-1 being important for kind of antiplatelet and gastrocytoprotection, whilst COX-2 is more the anti-inflammatory action. They're all used particularly in kind of rheumatological conditions such as rheumatoid arthritis, osteoarthritis, and obviously any pain due to inflammation is going to indicate the use of these drugs. They're all NSAIDs, so they share common side effects, particularly gastrointestinal bleeding, ulcers, nausea, dyspepsia, asthma as well. So because of that, you typically wouldn't prescribe it in someone who has asthma. That being said, these tables that I provided don't actually illustrate what we call contraindications. And these contraindications weren't outlined in the learning objectives, but essentially contraindications are where you would not prescribe the drug because of some kind of issue. So for example, NSAIDs will raise your liver enzymes. So therefore it is contraindicated in people who have hepatic impairment already. Another example might be, with NSAIDs, you would never prescribe it with a diuretic and an ACE inhibitor. We call that the triple whammy. And that's because that leads to renal failure, acute kidney injury, essentially. And then also, typically, you wouldn't use NSAIDs in people who, in women who are pregnant, just because they might increase the risk of miscarriage. So yeah, it would be useful for you guys to go back and kind of revisit those links that I provided a few slides ago, just to kind of have a look at when these drugs might be contraindicated. But yeah, usually it's pretty straightforward. So yeah, I won't go through the mechanism of action. They're all pretty similar, essentially just inhibits prostaglandin, prostacyclin, and thromboxane synthesis from the pathway that I will outline soon. So here we have the COX pathway, and I've kind of drawn a diagram here to kind of outline this pathway in a pretty simple way. So the initial trigger is going to be some kind of irritation or injury to the tissue, and an enzyme known as phospholipase A2 will be released, which essentially converts phospholipids in your cell membrane into arachidonic acid. So arachidonic acid is a substrate for both 5-lipooxygenase and cyclooxygenase. And then cyclooxygenase, you've got your two pathways, COX-1 and COX-2. COX-1 kind of being for your gastrointestinal system, to do with your blood in terms of platelet aggregation. So those are important kind of in hematology. And then the one that you'll be interested in particular is COX-2, which is kind of mediation of inflammation, pain, and fever. And essentially NSAIDs are going to target this part of the COX pathway. So because they target that area, they're obviously going to have some kind of anti-inflammatory, antipyretic, or analgesic effects. So yeah, I tried to break it down for you here. Okay, so that kind of covers the general introduction. Now we'll go into a few more different classes from the second lecture, particularly looking at steroids. So just a brief overview of steroids. So we've got glucocorticoids that are produced by the adrenal glands, and they are produced by the zona fasciculata of the adrenal cortex. So your adrenal cortex here is made up of the glomerulosa, the fasciculata, and the reticularis, and it's the fasciculata that produces glucocorticoids. Essentially, steroids will affect carbohydrate and protein metabolism, but essentially, if you have more than normal doses of steroids, you can achieve an anti-inflammatory effect. In terms of synthesis of steroids and how steroids are made, it's not particularly high yield, but just kind of like a brief overview. And one of the key takeaways is that cholesterol is a precursor molecule for kind of all steroid synthesis, regardless of whether it is produced in the glomerulosa, the fasciculata, or the reticularis. You've got a bunch of enzymes that are involved as well. So we've got CYPs, which are known as cytochromes, and they're basically a super family of enzymes that contain heme as a cofactor, that helps oxidize steroids essentially. So yeah, bunch of CYPs involved. Cholesterol is a precursor molecule for steroids. That's really all you need to know, I feel like. In terms of its anti-inflammatory action, so steroids will do basically the opposite of inflammation. I guess that's pretty, self-explanatory. But you've got decreased vasodilation, less swelling. You've got a decrease in the number of leukocytes that are recruited, decreased fibroblast function, decreased production of eicosanoids, so an inflammatory mediator, decreased production of cytokines, again, an inflammatory mediator, decreased synthesis of nitrous oxide, and then decreased histamine release as well. So there's three steroids, glucocorticoids, that faculty wants you to know. They are prednisolone, dexamethasone, and fluticasone. And again, these can be found on either two of these links. So we'll go into a little bit detail about that now. So mechanism of action for prednisolone and dexamethasone is they alter gene expression, resulting in a suppression of the inflammatory response. And all of these drugs are kind of indicated in inflammatory conditions such as arthritis, other allergic diseases. In asthma, they might be paired with other medications, such as Ventolin, to kind of relieve those symptoms. Side effects that you can get are hypokalemia and hyperglycemia. In the case of where you use steroids, too often at high doses, you can get what you call Cushing's, which I'll go into a bit more detail on the next slide. With fluticasone, it's got a bit of a different mechanism of action. Essentially, it will bind to the glucocorticoid receptor, which inhibits cytokine transcription, essentially reducing the number of many kind of inflammatory cells, such as eosinophils, macrophages, lymphocytes. So yeah, side effects for fluticasone include sore throat, dysphonia, which is kind of a hoarse or croaky voice, oral candidiasis, so a fungal infection if given orally, and then again, Cushing's. And just some other side effects that are noted at the bottom here. Osteoporosis, hypertension, some of the other ones. Kind of looking at long-term use with glucocorticoids, excess production of steroids or excess kind of consumption of steroids can result in what we call Cushing's syndrome. And essentially, it results in a number of physical changes. So in males, you can get, the presence of breasts, so gynecomastia. You can get moon face, which is a really typical sign, so a very kind of enlarged face. You can get kind of swelling, so edema, particularly in the shoulder area as a result of sodium and fluid retention. There's a number of kind of gastrointestinal discomforts. In women, you can get kind of amenorrhea, so kind of lack of periods. Purple striae or kind of bruising on your leg are also pretty common, and then osteoporosis is a side effect from the steroid use as well. So kind of the key takeaway with steroids is it's pretty hard to kind of withdraw steroid use completely. It's better to essentially wean them off, otherwise your adrenal glands won't kind of be given enough time to produce their own endogenous steroids to compensate for the ones that you're taking. So yeah, that wraps up pharmacology for week 6. As always, please feel free to message me on Messenger or Facebook. And yeah, I hope you find these tables a useful resource, but definitely check out ePharm and AMH as well.
Hi everyone, welcome to today's Pain and Temp lecture. We're going to be covering 1 and 2, and okay. So first of all, we're going to be focusing on the anterolateral tract, which comprises of the spinothalamic tract, the spinoreticcular tract, and the spinomesencephalic tract. If we have a look at this diagram, we're going to be focusing on this anterior spinothalamic tract, and on this side, the lateral spinothalamic tract. They sense different things. On this side, it's touch and itch, and on this side, it's pain, temperature, and sexual sensations. And we'll also look at the differences between them too. Another way to look at it is in this diagram. 3A is the lateral spinothalamic tract, spine to thalamus, and 3B is the anterior. Here we can see first order neurons, second and third order neurons. If you remember last week, we looked at this diagram and we learned that first order neurons are between the stimulus or the receptors and the spinal cord. Second order are between the spinal cord and the thalamus, and then thalamus to cortex is third order. Now we're looking at in this diagram. So these would both be first order, except one is superior to the other. Then the one that decussates here is the second order, and the third order would be going from the thalamus to the cortex. What happens if there's a lesion at one of the nerves? What if it's a lesion at a first order neuron? First order neuron is going to the spinal cord. So let's have a look at lesion 1 and lesion 2. They're both first order, but lesion 1 is inferior to lesion 2. Therefore, you'd see a loss of sensation in that specific area. What happens if there's a lesion at lesion 3? Here you can see that both second order neurons have been cut. That's up and lower, and therefore a lesion of the lateral spinothalamic tracts, or the second order neurons, would lead to a loss of pain and temperature sensation on the contralateral side of the body. So here it's the opposite side of where you'd lose the sensation. Sensory pathways from the face and the head. There is a cranial nerve called the trigeminal nerve. It's cranial nerve 5. So CN5. And there are first, second, and third order neurons as well. First order neurons will travel via 3 branches, cranial nerve 5-1, 5-2, and 5-3, to the trigeminal ganglion. The cell bodies sit in here. And then second order neurons decussate at the level of the brainstem and project contralaterally, and then third order neurons will reach the thalamus. Ventral, posterolateral thalamic nucleus. If we break this down, it's ventral, posterior, and lateral, right here. And ventral, posterior, medial thalamic nucleus would be on the inside. And these detect different things, as we talked about, and we're going to be covering mostly pain, but a little bit of the others as well. First of all, pain and neurological examination. There are some terms that we have to know: paresthesia, a spontaneous abnormal sensation. This could just be pins and needles, therefore it doesn't imply that it's painful. Dysesthesia, an abnormal and unpleasant sensation, so itching, burning, pain, electric shock. Allodynia is a subtype of dysesthesia that manifests with a painful sensation triggered by a stimulus that is normally painless. So now we're seeing pain when it shouldn't be painful. Hyperesthesia is a subtype of dysesthesia that manifests with an exaggerated perception of sensory stimuli. Meaning in a normal person with normal neuronal structures, they would feel some pain, but a person experiencing hyperesthesia would feel more pain than that person with normal neuronal pathways would feel. And hyperesthesia is decreased perception of sensory stimuli. And the most extreme case of this is anesthesia. What happens when we have injury? We will have a tissue response to that, and NSAIDs can help with pain management. NSAIDs, non-steroidal anti-inflammatory drugs, have a reversible effect at inhibiting the enzymes COX-1 and COX-2 to decrease prostaglandin synthesis. Out of the NSAIDs, aspirin is the exception because it leads to irreversible COX-1 and COX-2 inhibition. A reminder that last week we covered Merkel discs, Ruffini, Meissner, and Pacinian corpuscles. And I've put this here so that you can refer to it when you're looking at this week's lecture as well. Because on top of the ones that we just learned last week, these ones, we're going to be learning about free nerve endings. They're right here. They don't look the same as the other discs and corpuscles we learned about last week, and they carry pain and temperature. Here's another provision too. C fibers are much slower than A delta fibers, but they both carry pain. So let's look at the classes of nociceptors. First of all, A delta fibers. There are 2 types, type 1 and type 2. If we compare them, type 1 has a high threshold mechanical receptor. It's got a relatively high heat threshold, and it's the first response to intense mechanical stimuli. And if heat stimulus persists, meaning if the stimulus is still there and there's no instinct to remove your hand from like the stove, for example, then you become sensitized to that heat. And then if you become sensitized, it means the threshold of pain has reduced. Type 2 is different. It's thermal rather than mechanical, and it has a lower heat threshold and a higher mechanical threshold, which mediates the first or fast acute pain response to noxious heat. And if you can figure out what would be the acute pain response to noxious heat, it would be the instinct to take your hand away from the source of heat. Out of the C fibers now, we're going to be talking about nociceptive, silent, itch, and non-nociceptive C fibers. Nociceptive means like pain transmitting. So pain transmitting C fibers, they respond to dangerous heat mechanical stimuli. Silent C fibers are heat responsive, but they become unsilenced when they respond to chemical stimuli, and they have a role in inflammation. They develop mechanical hyperalgesia. Remember, hyperalgesia is abnormal pain perception due to increased neuronal sensitivity to noxious stimuli. Itch C fibers respond to itch-initiating chemical irritants, such as histamine. Histamine is something we release during allergic reactions, and non-nociceptive C fibers. Some respond to cooling, cold stimuli. Some respond to harmless stroking of hairy skin. This would not really be a threat to us. And that was pain 1. Let's move to pain 2. For pain 2, there's a lot of definitions, and I've put a lot of extra info, mostly for interest. So if that's something you'd be interested in, then you are welcome to have a look at it. I just realized this is not even full screen. Okay, now it's full screen. Sorry about that. So why do we feel pain? First of all, acute physiological or nociceptive pain. Remember, nociceptive is pain in response to mechanical, thermal, and or chemical stimuli, and it's sensed by somatic sensory receptors called nociceptors. This is our survival, our protective mechanism. On the other hand, chronic and persistent pain happens when we have persistent injury to the nervous system. In this case, we'd experience plasticity, enhanced pain signaling, hypersensitivity, and because it's due to chronic pain or injury, it has no obvious advantage to us. Plasticity is the transition from acute to chronic pain and is associated with structural plasticity or reorganization of the circuit at various points in the somatosensory pain circuit. For inflammatory reasons, tissue damage or acute chronic inflammatory conditions, we also can experience neuropathic pain due to central or peripheral nerve damage. And the symptoms of pain are hyperalgesia, when it's pain responses to noxious stimuli are exaggerated, or we are feeling more pain than it should be, versus allodynia, when it's painful when it normally wouldn't be painful. Pain produced by normally innocuous stimuli. The definitions are also in the at the bottom. We've also got a chart here, a graph here to explain it in diagram form. Okay, different types of pain. Nociceptive, so that's pain via something to keep us safe, protective. Pain, neuropathic pain, this can happen in diabetes patients, in post-stroke patients, and we'll learn more about that, as well as inflammatory pain. Pain here will promote healing by preventing contact and movement of that area, and it's associated with tissue damage and inflammation. Remember that nociceptive pain was the pain that is triggered by the stimuli, that's mechanical or chemical, and neuropathic pain is pain that's caused by abnormal neural activity that arises secondary to injury, disease, or dysfunction of the nervous system. And we've got a few interesting neuropathic situations we'll learn about today. If you can remember this diagram, you wouldn't have been introduced to the sodium voltage channels to this specificity yet, but you can probably remember the depolarization and the repolarization steps. We remember that sodium voltage gated channels are required for the depolarization, and therefore, if you are able to depolarize a nerve, it would be able to transmit pain. So what's the best way to block nerve transmission in anesthesia or in pain medication? And that is to stop the sodium gated channels. You can see here there's 9, and they target different phases. And the best local anesthetic, or the purpose of it, is to block all 9 sodium channel subtypes. Sodium channels are a prime target for therapeutic intervention and has potential for selectivity, meaning that you would be able to target sodium gated channel 1.7, for example, if you only wanted to target inflammation or inflammatory pain, and sodium gated 1.8 to target for treating extreme hypersensitivity to cold. Local anesthetics are used to treat neuropathic pain, and sodium plus sodium channel blockers are used as therapeutic agents. Neuropathic pain. Neuropathic pain is pain caused by an abnormal neural activity that arises secondary to injury. Central pain is pain caused by central nervous system dysfunction, and this can be due to lesions produced by a stroke or phantom limb pain, which we'll cover. Peripheral pain is caused by damage to peripheral nerves, as we discussed, diabetic neuropathy, or post-herpetic neuralgia, which is post-herpes, and sympathetically mediated pain, which is caused by damage to autonomic nerves. Microglial activation in the dorsal horn. Microglial cells are phagocytic. So they are activated in response to CNS tissue damage. They proliferate and migrate to the area of damage to remove cellular debris. Intuitively, it would probably make sense if you want to clear out any debris, especially if it were to be on the spinal cord. You wouldn't want to interfere with any of the other nerves in the area. But because there's phagocytic action of the nervous system, and because there's inflammatory mediators and signaling molecules that are happening, it can cause neuronal damage through the release of potentially cytotoxic molecules. And this is associated with HIV-associated dementia as well. Visceral and referred pain. So we're going to learn about phantom limb pain. Phantom limb pain happens when someone has amputated a limb. In this case, it's this person's right foot, but they feel pain that comes from that right foot. And it can be really disorientating for them, especially if you're feeling pain in a limb that's not there anymore. And how it happens is that when you amputate this limb, the nerves get confused. And the phrase is neurons that fire together, wire together. So neurons in the sensory, motor, and pain perception networks of that spot becomes entangled. And so you will feel pain in the amputated limb. The pathophys of this is primary somatosensory cortex neurons that formally respond to signals from the limb when it was there, now responds to signals from neurons close by that carry sensation from other parts of the body. And this is happening because there's a functional reorganization of the somatosensory cortex. Another important concept that you'll learn this year and next year is visceral pain, and comparing that with referred pain. Essentially, there's also the type of pain, musculoskeletal pain. So if you have pathophys, if you have pathology in your deltoid, then you'll feel pain in your shoulder. That's quite intuitive. Visceral pain is dull, diffuse, and deep pain. So it's not like a specific location and it's not sharp pain. It could be something to do with your GIT, and then you'll feel, then that person would feel deep pain. That tells us that it's from an internal organ. Referred pain is really interesting. It's when there's pain somewhere. In this case, if you have a look at diaphragm C4, there's pain on the left shoulder, but it's actually indicative of pathology at the diaphragm. And the same thing for what looks abnormal? Maybe the heart. The heart is very far on that side. And the reason why it is that way is the nerves grew up. The nerves developed together. And then the nerves that are innervating the diaphragm, C4, are from the cervical plexus. And that's why it innervates at a completely different place. You will have a lot of opportunities to learn about innervation of the diaphragm, but it's a very important issue. It's a very important topic. And so it's good to remember that the diaphragm is innervated by C2, C3, C4. And the diaphragm is innervated by C4 and pain goes to the left shoulder. C4, C3, C4, C5, sorry, not C2, 3, 4. C3, C4, C5 keeps the diaphragm alive. Okay, next, post-stroke pain. So central post-stroke pain affects less than 10% of all stroke patients and can occur with thalamic lesions. What we'd see is unilateral facial pain, that's on one side, and or extremity pain associated with previous stroke. Contralateral or ipsilateral initial paresthesia, followed by neuropathic pain, for example, allodynia and dysesthesia, as well as neuropathic pain. Here you can see this patient has pain on their entire right side, entire left side, or the opposite sections. Pathological pain without nociceptor activation. So if you have a look at this cross-section here, we can see lamina 1, 2, and 5 as well. And so this is just telling us that lamina 1 and 2 go to nociceptive specific neurons, whereas lamina 5 are wide dynamic range neurons, and they're sensitive to different types of somatic input. They respond preferentially, but not exclusively, to nociceptive stimuli. Next, gate control theory. The gate control theory is a way we explain how there may be a stimulus of pain. Think of someone who might have chronic pain, but there are things that you can do to flood the gates that would be transmitting that pain so that the actual pain is not sensed, or at least it's reduced. That's gate control theory. So we're inhibiting the transmission of pain messages. If we fire A beta fibers and it activates the inhibitory interneuron, if we turn this on, it stops the projection neuron from firing. And so even if we have pain fibers going to the projection neuron is unable to fire the pain transmission. Analgesic drugs are acting in the nociceptive system. So we want to be very careful with the drugs that we prescribe, and we prescribe correctly to the type of pain there is. And so here we can see that opioids are commonly used by doctors because they target so many areas, whereas others are pretty specific and things like that. Intrinsic descending inhibitory pathway modulates nociceptive input. The goal of this pathway is to allow the organism to function enough to respond to the pain source. So think of protective feature, but it reduces the pain signal through neuronal inhibition. The descending pain control pathways can be both facilitatory as well as inhibitory. And inhibitory pathways suppress pain perception. Next, morphine. How does morphine work, and how does it help us block transmission of pain? Here we have mu opioid receptors, and we have morphine, which will attach to the mu opioid receptors. So when they bind, they directly act on these receptors, which are pain modulating. And when you activate pain modulating receptors, it blunts the effect of signaling systems that transmit pain. And that's all. This topic was quite tricky, so you're welcome to text me if you have any questions. Good luck.
Okay, so I'll be going through modulation of nerve conduction. So this is essentially a lecture that's all about local anesthetics. So the learning objectives in simple terms is to firstly understand how local anesthetics work. Secondly, understand what changes, how effective they are in doing their mechanism of action. And then thirdly, understanding how they can be delivered and their possible adverse effects. So the mechanism of action of local anesthetics is essentially all targeting the action of Na voltage-gated channels, so sodium voltage-gated channels. So the way this works is you have nociceptors, and this works through a pain stimulus coming through. And this works through a depolarization cascade where you have the Na channels that open during the depolarization cascade to allow depolarization to occur and the membrane potential to move throughout the cell. So essentially, the action of local anesthetics is to stop these Na channels from activating in this part of the depolarization, and therefore stop the nerve signal from coming. And what we have to remember is that since depolarization is an all or nothing response, what that means is if you stop depolarization from occurring, that essentially stops the entire nerve signal from going through, which results in a very effective blocking of pain. So the structure of anesthetics is important only because it can affect the effectiveness of anesthetics. So there are two main categories of anesthetics. These are esters and amides. So a local anesthetic has three main components. So there's an aromatic group, which is usually a benzene ring. Then there's an intermediate chain, and then a tertiary amine. So the intermediate chain, which is this middle section here on the diagram on the right, is the only part that changes. And this can either be an ester or an amide. And as a result, there are two main categories of local anesthetics. So the reason why this is important is that amides and esters are metabolized by the body in different ways. So amide local anesthetics are metabolized in the liver by the cytochrome P450 enzymes. So as a result, they are longer lasting, as opposed to esters, which are metabolized in tissue by tissue esterases, which are shorter lasting. And a way to remember or quickly think to yourself about whether a local anesthetic is an amide or an ester is to think about the I rule. So if a local anesthetic has an I in the first part of its name, aka lignocaine, then it's likely to be an amide. Whereas if there's no I in the first part of the name, it's more likely to be an ester, so a methicaine. So now to move on to talk about some of the factors affecting the action of local anesthetics, there are four main things to understand. Firstly, lipid solubility and potency, ionization status, use dependence, and vasoconstrictor and vasodilators. So we'll talk about each of these one by one. To start by talking about lipid solubility and potency, the first thing that you need to remember is that a local anesthetic blocks the intracellular part of the Na-gated channel. So we talked about how depolarization occurs because of the opening of Na voltage channels. What happens is that the local anesthetic has to cross the cell membrane to go inside the cell to then block that Na channel from the inside of the cell. So what that means is that if the local anesthetic cannot cross the cell membrane, it cannot get inside the cell and therefore block the Na channel from inside the cell. So that means is if a local anesthetic has higher lipophilicity, it will have higher potency because it's more likely to be able to cross into the cell and block the Na channels. So we'll also talk a little bit about the types of fibers. So when a fiber is more myelinated, aka when you go from C fibers to A delta to A beta to A alpha fibers, it's also harder for the local anesthetic to travel through that myelin sheath and therefore to block the NA channels. So what that means is that the fibers that are least myelinated, aka the C fibers, are the ones that are first blocked. But say you had a large amount of local anesthetic in a certain area, then they would start to seep through the myelin sheaths and also then block other nerve fibers, such as cold and warmth from the A delta fibers, or touch and deep touch and pressure from motor fibers from like the A beta fibers. The second factor affecting how potent local anesthetic is ionization and pH. So this again relates to the same concept, which is that local anesthetics have to pass through the cell membrane. So local anesthetics are weak bases, which means that at lower pHs, so in acidic conditions, they are more ionized. And what you need to know is that it's the unionized form of local anesthetics that pass through the plasma membrane to bind onto the NA channel from the inside. So as a result, local anesthetics are more effective at high pH, whereas at lower pH, for example, which can occur in inflammation, local anesthetics are less effective. Excuse me. And this is important to know because, for example, if you're doing a dental procedure, for example, there can be inflammation in the gums. So the local anesthetic you provide to that area is likely to be less effective if there is inflammation than if there wasn't inflammation in that area. The third factor to consider is this idea of use dependence, which is that local anesthetics only block sodium channels in the open and inactive states. So what that means is there are three main states of sodium channels. So there's closed, which is just nothing's happening, open when the depolarization is occurring, and then when they're inactivated, which is when repolarization is occurring. Local anesthetics can only bind to the sodium channels when they're open or inactivated. And basically, if a nerve is being used more, aka more signals are being sent through the nerve, then more of the NA channels will be in the open and inactive states, which means that as a result, more the local anesthetic will be able to bind to the inactive or open channels much more easily. Finally, to talk about vasoconstriction and vasodilation. Vasodilation means increased blood flow and vasoconstriction means reduced blood flow. This is fairly intuitive in that, like, if you inject a local anesthetic to a certain area, if there is more blood flow, that means that the local anesthetic is more likely to be taken to other parts of the body, which means that there will be increased systemic distribution and reduced action of the local anesthetic in the local area. However, if there's less blood flow, there's less likely to be local anesthetic distributed throughout the system, and therefore there's more likely to be a prolonged local anesthetic effect, which is the reason why a lot of local anesthetics are provided with vasoconstrictors, for example, noradrenaline or epinephrine, which is written here, but just adrenaline. So to sort of wrap up this section, I'll talk a little bit about adverse effects. So the adverse effects of local anesthetics basically arise from the blockage of those NA channels and like what happens when this occurs at a greater scale. So in the central nervous system, you have, depending on the dose, you can have central nervous system depression and convulsions, which just means slowing of your movements, and convulsions. Can also have restlessness, shivering, tongue numbness, or a metallic taste in your mouth. You can also have respiratory depression, where the entire respiratory system slows down. In the cardiovascular system, you can have myocardial depression, conduction block, and vasodilation. So to talk a little bit about methods of administration, it's important to think about why you actually use local anesthetics in these ways. So there are a few ways here. Topically, you'd use it for injection at a surface. Infiltration, you'd use for local surgery. Intravenous regionally, you'd use for where you'd inject a local anesthetic, but you'd block off an entire part of a limb, which would result in the entire limb getting numb. So this would be for limb surgery. Nerve blocks used a lot in dentistry, and epidural for blocking an entire spinal canal, for example. These are now the drugs at the end here. And I won't necessarily go through all of these, but it's just nice to know that the mechanism of action for all of these drugs is exactly the same. And then it's just nice to know whether they're an amide or an ester to know whether they would have long-acting or short-acting consequences. And then it's also nice to know some of the adverse effects, most of which is just allergy, or cardiotoxicity or skin redness that we talked about before already. And that's it with local anesthetics.
Okie doke. So we are moving into everyone's favorite, Clin skills, and today we're talking about the upper limb neuro examination. So just a quick sort of chat about the dermatomes for your upper limb. So this diagram is a really good diagram to show you each dermatome, and it's really important to remember this because innervation with the dermatomes and your myotomes will be quite important for your exam and for your examinations. And yep, so this is also for your myotomes here. So when we're talking about upper limb, we're talking about shoulders, elbows, wrists, and fingers, as I'm sure you guys already know. And this is just a bit of a summary slide for you guys to have a look over later, just showing you all the different innervations for each of the myotomes. So yeah, let's jump into the examination specifically. Just hide that. So we're always going to start off an examination with inspection. So that starts off with general appearance. You're checking the patient's just demeanor, if they seem comfortable, if there's any pain that they're in, if there's anything that they'd like to bring up. You're also checking their posture. Just to see if there's, once again, it will indicate pain or if they have any sort of musculoskeletal problems at all. You're also going to be checking for the arm drift test. It's more so part of the inspection because it doesn't really fit anywhere else. So as you can see in this picture here, the arm drift test is you're going to ask someone to hold their arms out for you like this, and get them to close their eyes and just hold it there. And if you've got any sort of neuro problems there, their arm will tend to drift. It could go up, it could go down, and we'll talk a little bit more about the specifics of that in future presentations, I think. So yeah, we'll go into that a bit more later. Yep, so for the other parts of your examination inspection, you're also looking for just any sort of visible abnormalities on the skin, scars, rashes, discoloration, any sort of abnormal movements. So for example, tremors. You're also looking for fasciculation, so that's muscle contraction without like intentional movement. And you're also looking for any signs of muscle wasting. And in this case, that would be within the upper limb. So we're going to start off with the examination for the motor system specifically. We've already had a bit of a talk about tone and power, so you can read a bit more about that in previous presentations. I think that was week 3. We did more on that. But just to kind of summarize for the upper limb, when you're talking about tone, you're talking about the freedom of movement of a joint when you, as an examiner, are moving that passively for the patient. And if you're seeing that there's increased tone, that's something we refer to as hypertonia. And if you're seeing reduced, that's hypotonia. And then we're moving on to power. So when you're talking power, we're talking here strength through resistance. So that's the patient will try to do a movement and you're going to resist them like that and see how strong their resistance is. And once again, in that week 3 presentation, we talked a little bit more about the grading system. So it's a scale from 0 to 5 in terms of the level of power that someone has. When you're testing it, it's always good to isolate the muscle by holding the limb above the joint. So say, for example, if you're testing power within a good example is the wrist, actually. When you're testing your power in your wrist, it's always good to kind of hold this area here. So then when you're doing the test, the resistance isn't coming from anywhere above the wrist in any of the other joints or any other muscles. It's all coming from what you're trying to isolate. So that's something to remember. And it's always important to remember to not assess the power in one of your joints simultaneously. So don't do both wrists at the same time, for example. Again, it won't give us good of a representation of that individual power in that individual joint. And it can also cause harm to the patient at times. So always good to avoid that. And another important thing to remember is it's always good to test active movement first. So get the patient to show you what their movement capability is, because you don't want to jump into something and cause resistance to the patient and end up injuring them because it wasn't the right amount or it was too strong for them. So moving on to reflexes, we use this sort of a system. So when there's an absent sign for reflexes, you just put a 0, and then all the way to the other end of the scale for exaggerated reflexes and clonus, where there's involuntary movement, that's when you put the 4+ signs. And so if you ever see that in any of your ICL presentations or any just sort of write-up about a patient's reflexes, this might be the terminology and the system that they use. So when you're testing reflexes, it's always good to ask the patient to close their eyes or clench their teeth if you feel like they're focusing too much on the reflex, just so you get a better example, a better representation rather of just an involuntary reflex. And when you're testing, it's always good to place your finger on the actual insertion point for that tendon that you're testing, just so that the hammer doesn't hurt them. You're going to hit your finger instead of their actual skin. And it's always good to make sure to do that at a right angle like that. We unfortunately probably don't have enough time to go through each individual reflex, but as always, feel free to text me if you have any specific questions for a specific reflex. And there should be some good summary notes in the upcoming revision sessions you will have. Yep, so for coordination, still part of the motor system, there's three main things to cover here. So the first thing is ballistic tracking, where the patient is going to point their index finger and they're going to try to touch your index finger like this, and then you're going to move your finger horizontally to a new position and get them to follow that. The next thing is rapidly alternating movements. So the patient's going to pronate and supinate one hand like this as quickly as possible. It's good to do that on a surface, whether it's their own other hand or your hand or a tabletop or something like that. And if you're seeing that this movement is slow or clumsy or they're having trouble with it, very big word here. I probably won't try to pronounce that, but that's what that indicates. And so we're trying to observe their abilities with how fast they're able to do that, and also how like the quality of that movement as well. So if it's clumsy, even if it's fast, that's not a good indication either. The next thing we're going to look at here is the finger nose test. So the patient is going to touch their nose with their index finger and then reach out to your finger and outstretch their arm. They're gonna, I believe that's meant to be eyes open first and then closed. Sorry, I'll make that change. And you're gonna compare both sides. You're gonna do it for this hand first and then the other one. If you see that they have an intention tremor when they're doing this movement, so as they're reaching out, their hand is shaking, that's going to increase as you keep doing the movement. So that's something to observe there. And if you see that they undershoot or they overshoot in terms of trying to reach out to your finger, so say they think your finger is here and it's too far away, or they move too far away from your finger, that's an indication of dysmetria. And if there's any sort of breakdown of movement, so that's kind of like a clunky movement forward, or it's like really abrupt as they're reaching out, that's an indication of dyskinesia. So these are all different things to look for when you're doing coordination. One of the main things to double check here is the finger nose test, because that's a really good indication for the intention tremor. Alrighty, so moving on to the sensory system now. Just for all things sensory, here's some things to remember. Always important to test when the patient's eyes are closed, because when we're looking at the sensory system, it's going to be a lot about seeing if the patient is able to feel different stimuli across their arm and their upper limb. So if they've got their eyes open, they're just going to be able to observe it and not give you an accurate representation of if they can feel it or not. So make sure their eyes are closed. It's always good to start proximally and then move distally down the limb, except for the two sections that we'll talk about a bit later, so vibration and proprioception. But just as a rule of thumb, proximally to distally, except for those two. It's always good to check the sensation somewhere else first. So you want to make sure that you as an examiner are also pushing down with enough pressure or using the appropriate stimuli. So you want to check somewhere like their face first, where you know that they do have the appropriate sensation. And the last thing is make sure to compare sensation on both sides, and so that you get a good comparison, as well as just the one examination for maybe an injured upper limb or something like that. So always want to get that comparison. Okay, so here's all the different sections that you'll be covering. So first is pain. So you want to have an example of a blunt and a sharp object. A good example is something like a paper clip, where they've got the round end and the sharper point. And of course, you don't want to injure the patient, but you also want to make sure that you've got that distinction. And you want them to be able to tell the difference between a blunt and a sharp object as you test down the limb. So the next thing you're looking for is temperature. So using a tuning fork or any sort of cold metal, tuning fork is probably the easiest thing you'll be able to find in a doctor's office. And so you're using that to test if they're able to test for the cold. Next thing is light touch. So using like the wisp of a cotton ball, you're going to be touching straight down. So it's not really a rub, it's more of a press down on each dermatome, and you're going to see if they're able to feel that properly. Next thing is vibration. So this was one of the sections where we go from distal to proximal. And so for vibration, of course, we'll be using a tuning fork here. Always good to remember 128 hertz tuning fork. Check somewhere for reference. So example, the bottom of their foot first, and then ask them to tell you when they can feel the vibration, of course, but also remember to ask them to tell you when the vibration stops, so that you're also able to tell if they're able to sense the difference between that and how long it will take them to do that. Next section, where we start off with the distal joints first, the distal area first, is proprioception. So if it's normal at the most distal joint, there's no need to test any further. So that's why we do that. So what you're going to do is you are going to sort of follow them through movements. So you're going to start in the center and up and down. While you're doing that, you're going to hold their fingers from their sides, not from the top and bottom, because otherwise that can help guide them a little bit more. So first you're going to start doing the movements passively for them, and then you're going to shake it out, just give them a second to rest, and then they're going to try to do that for themselves with their eyes closed and see how they're able to do that. The next thing is the 2-point discrimination. So using a paper clip is always a good thing, because that's quite easy for you to bend out to form 2 points. And this is just so that you're able to check if the patient is able to determine the difference between 2 points compared to 1. And these are just some numbers for reference for when you're testing individual things. So for the hands, you'd like to keep the points around 3 centimeters apart, and for the fingers around 0.6 centimeters. And the last thing is stereognosis. So this is basically just, is a patient able to identify an object just by feeling it? Just a common object, for example, like a comb or something like that. Yep, so just moving on to the last bit for this section. With our peripheral nerves, we've got these 3 really major ones when we're talking upper limb. So we have the ulnar nerve, and we have the median nerve, and the radial nerve. And this is just a diagram for your reference to show where they innervate. So nerves to remember. So we'll start off with the radial nerve. That's innervated by C5 to C8. And there's a lot of different pathologies that can happen. So you can, yes, of course, that can happen. And then when you see these pathologies, this can cause things like wrist drop, and you can have a loss of sensation over the anatomical snuff box. And yep, but we're going to more focus on the median nerve and the ulnar nerve for now. So the median nerve is C6 to T1. Of course, that's when we're talking about carpal tunnel. We're relating it to the median nerve. And then these are some examples of where you see the pathology evidence. So you're not able to abduct your thumb, you can't flex your index finger, the hand of benediction, which we'll talk about in the next slide, and the wasting of the thenna eminence, and of course the sensory loss of the lateral 3.5 digits. So again, there's another diagram here for you to have a look at that while you read through this. And the next one we're talking about is the ulnar nerve, which is C8 to T1. So you're going to see wasting of the hypothenna eminence if there's any problems with the ulnar nerve, the ulnar claw, which again we'll talk about in the next slide, and you'll have loss of sensation over the medial 1.5 digits as well. Okay, so this is a really good summary table for a comparison between the ulnar claw and the hand of benediction. So when you're talking the ulnar claw, of course, it's the ulnar nerve at the wrist. Hand of benediction is the median nerve at the elbow or at the wrist. For ulnar claw, you've got the typical presentation of more long-standing cases, because it's more of a pathology that you see all of the time, just naturally when the patient is at rest, in comparison to the hand of benediction, where you see that when the patient attempts to make a fist. And the digits affected are the little and ring for ulnar claw, middle and index for hand of benediction. There's the muscles that are paralyzed, and the movements involved. So when we're talking ulnar claw, we are seeing that there's unopposed extension at the MCP joints, and there's unopposed flexion at the IP joints, in comparison to the hand of benediction, where it's actually you're unable to flex at the MCP and IP joints of the middle and the index fingers. And that's why you see a similar sort of shape, except one is because you are just constantly in that state, whereas the other one, the hand of benediction, is because you're unable to actually flex the way you would like to. And also for the hand of benediction, you have voluntary flexion at the MCP and IP joints of the ring and little fingers. So that's still possible there. And this is just a really good diagram here. It also includes wrist drop, so you get that little extra information, but here you can see the hand of benediction benediction or the bishop's hand. It might be called in some resources, and the claw hand here. And as we were saying, hand of benediction is when you're trying to make a fist, these areas here stay open. And when you have claw hand, that's just naturally staying in that position because you're unable to extend and flex in these joints here. And that's me all done.